bush, and also talk about settled human settlements. In terms of settled human settlements, we do know that when the Gulu and Masindi outbreaks happened in 2001 in Uganda, we had Kenyan children from Busia who had gone to see their grandmother in Masindi. And this grandmother had been taken to Gulu Hospital, which was the big mission hospital. And then when Ebola broke out, there was no separation of the nurses. And then the children was made to send them home. So when she was sent to where she had come from in Masindi, back to the grandchildren who had come from Kenya, then the process continued. She was being nursed at home, and she moved there already contaminated, unaware, because they did not put them under any quarantine. And then when she passed on, some other Kenyan moved in there, went all the way for funeral. It is that time that two Kenyans, I will not mention their names, so I still remember them very well. When they finished the burial, they were told the Ugandan government was going for them to quarantine them. So they disappeared in the night with the children. A whole party of about 13 or 17 people moved back to Kenya. And so they were very good. They reached before they could be detected. And so we were told to hunt for them. When we hunted for them and got all of them, quarantined in Busia Hospital, two of them tested IgM, IgG positive, they were IgM negative. Means they had gotten small doses and developed some immunity, and they did not develop clinical disease. And this is part of the effort that was done in parts of DRC, parts of West Africa, and for the people who actually pick up immunity and don't get sick. So that's a vulnerable individual. So back to the transmission routes, and this is basically what we're going to be talking about. That the basic route is contact. So when we have contact, means you will get into contact with the human body or any article used by a human being who has particular disease, and then without effective hand hygiene or by aerosolization, then it gets there. Or there are some people who blow things as a way of cleaning. It can get into through the eyes, through the nose, through a blow, or even whatever. Even like sharing a cup is contact, sharing a spoon is contact, sharing a bed is contact. So a couple of all those aspects will transmit. The reason we are belaboring this again is so that we do not ambush people. And you see, we have an African behavior where somebody is sick, people tend to go and show, to console the sick person. And as they're going to encourage them, they will go and share a lot of things together. Then they migrate back to where they came from and take a disease. And it's very important because when I'm speaking to nurses, and I know it is nurses that are in every aspect of healthcare, in terms of preventive health, promotive health, and including curative health, and even to a big extent also in rehabilitative health. So with all these stages, it's only therefore the nurse must know that Ebola will be infectious even when there is no overt signs and symptoms. Not like what we say, unless you have an active fever, meaning you have distribution. It also happens. Like measles, we say it is 4 days before rash onset and 4 days after rash onset. That's the most infectious period. So Ebola will take that kind of fashion because people start with very subtle signs and symptoms that you may not even guess, you may not know, and they alert the moment you're told, and you have people beginning to strengthen surveillance. Then people who are in clinical settings where sicker people spread it more because the viruses are more violent, they're not being scattered by the body immunity, then a lot of transmission. Droplets, we remember when you pass urine, there some urine will scatter, some whatever, even stool. Sometimes if it's loose, it will splatter at different places. It will carry the virus. Again, children who cry, children who cough, who laugh, who shout, who sneeze, all these have respiratory droplets, and they are loaded with the with the Ebola virus, and together with all other viruses transmitted by that route. Then also, when it comes to people who breathe very hard because they begin to have inflammatory processes across everywhere in the body then produce also more pathogens. And that is why when people who also tend to feel cold because they're running some fever, they're febrile, then they will be pushing in a lot of fluids into the environment. So we need to look at all those areas of care. In terms of nursing care, the patients require intensive care for a highly inflamed patient. A patient who has viral inflammation has tissue breakdown, has a lot of fever, has dehydration, and sometimes get a bit mentally confused depending on the homeostasis in terms of fluid balance and electrolytes. They get very weak because of the depletion of the electrolyte level. And so we need to be able to emphasize to nurses during, that's why I said I'm taking the form of a wardrobe. When you're taking care of patients in that setting, then you need to be sure that you are ensuring all articles that leave the patient room are put in a contaminated container, whether it's a linen bag or it's some other things, plastic bins where they will be soaked to decontaminate before they are washed, if they can be washed. But most of the times they are told, please discard them. And that's why whenever you walk in with any item, even a watch, the watch you use must be mounted on the wall, must have a second hand for you to count breaths, respirations, pulse, and whatsoever. If you don't have an electronic one, that will do. And if for patients it's not shared, and again, you respect that we may not need to share because we're not even too sure what is happening in the current situation. What are the difficult situations the nurse will find themselves in at this particular time, in this outbreak? And should any Americans be brought, they may not bring us an American nurse. If, like, okay, we know the court has stopped, but I'd say, what would the nurse expect to be the biggest challenge? Number one, we do not know the relationship between the present day Budibugyo strain virus with the original one. That happened, I think, 2006. And the reason we do not know is the so-called Americans and the Kenyan system, they have not told us they've collected the old virus. They've done a molecular characterization to look at its DNA description as compared to the one that has been detected in DRC. DRC has had a lot of outbreaks, but they've never detected the Budibujo. How did it move from Budibujo inside of Uganda to go and emerge in the inside of Ituri province in the eastern DRC? I know they're neighboring, but what is the mechanism of how it was transferred? So that is a question that the nurses need to ask. Now, when we know this, the case fatality rate for Budibujo was higher, yet Uganda had developed more high capacity for coping with the virus than they had observed from the Sudan strain in 2002. So that therefore means Kenya is not prepared to just collect nurses and bundle them and say, we are heading to the Budibujo Ebola outbreak quarantine and management, and when they pass urine, you clean their condom. I don't think that Kenya is ready. So the other thing that we need to appreciate is Kenya has a lot of bats. The reservoir, one of the wild reservoir is the fruit bats, not the common black, I don't know, they're black or dark gray bats that once are small. These are the ones that have a big snout and they have a head that looks like a donkey. I have seen a couple of those in Western Kenya. I've seen a couple of them in some parts of Nyanza. I have taken a photograph of one in Tana River. We know that the Museums of Kenya did collect even an Ebola virus from some parts of Taita Taveta, and we therefore suspect in the bushes of Kwale and a bit of Kilifi we could possibly have. So we actually have the reservoir. The main reservoir is that. But in a lot of literature support that all animals that eat fruits, including monkey, the whole range of the monkey families, whether they are gorillas, they are apes, they are There are tubiri, I don't know, whatever, all the names you can imagine. I don't know all of them, including gazelles that also eat, like the ones that feed like a goat. They can eat bananas, they can eat guavas, also mangoes, all of them, because the fruit bats inject and leave their saliva with viable virus in those fruits. So communities that do fruit gathering are very vulnerable to be carrying Ebola virus. And some of the parts of Nanyuki where they are proposing, we have large game reservoirs. And therefore, we do not know whether they are susceptible or not susceptible, and they could decimate the wildlife wealth of the country by so doing, or even expose the people who tend to wild animals in the animal sanctuaries unknowingly. There hasn't been sufficient community engagement or public engagement and to clarify all these issues. But they just want to bring enough problems, then say we are calling on our nurses to manage. Now, we have even a forensic nurse here. So that is not fair, and those are issues to consider. The clinical picture of the Sudan strain is slightly different from the clinical picture for the Budibujo strain. And I know my time is getting off, so because I was told to limit, I want to stop there, but allow me, if there's anybody the question I can respond to, I do. And but I will not disappear. If there'll be some more time to ask me question, I will be able to respond. Just try to say a little bit of that aspect.
Prof, I can give you next 10 minutes so that
Okay.
now we can join the next person.
Okay, thank you very much for that. So, okay. So now we need to be able to remember in nursing care, we do a day, we have to have a senior nurse, a very senior nurse. My background of training says they have an advanced practice nurse. I abbreviate that to be an APRAN, and when it's midwifery, APRAM. And I want to just say the time we had a pregnant mother, the husband collected the monkey from the bush and said, "This is very good for babies who are growing inside the stomach," and told the mother to cook. So when she finished cooking and they feasted, apparently, the man who carried the dead monkey, dead of the Ebola, did not contract infection. The mother contracted because she butchered, and then also, and when she was operated, because she had high fever at some, she infected a whole 42 people, including the obstetrician and all the nurse midwives were in the theater and post recovery, and everybody, they all died of Ebola. So we need to know that nurses are at a very highly exposed stage, and you may not know because she came with basically obstetrical symptoms. And the obstetrical system, because it's the most vulnerable system at that particular time before the systemic, the whole body vulnerability. So it's those issues that I want to emphasize. When you take history of patients this time around, take interest in movement, acquaintances, and different foods and whatever they have done, so that if you have a reason to suspect, alert, so that every other member of the health team, the nurses, are at very high level of the highest level of protection. Please do not gamble with your eyes and with your nose. Get a full gear, protective gear. Highest, like what you call the airborne infections isolation precautions. Don't breathe air that does not pass through the particulate filter, and that will be okay. Then immediately please ensure that the places where they create for you isolations, you see, like the one they built in Kenyatta. When I went there and I said I condemned it actually. I was told shut up, and I shut up. Please don't go to new ones they're doing where you don't have elaborate place to take a bath and then change, and then we better keep washing clothes. I tried to tell the Kenya National Nurses Union, whatever, National Midwives Union, whatever they call themselves, that we could do modeling to show that the nurses' uniform exposed to chlorine, that is the ideal for soaking and washing, so that you kill the viruses, then the cloth gets worn out in 3 to 6 months. But because of course, they are not scientific in the head, they snapped me. So that if you had produced such results, it would be reason to say, without this uniform allowance, without this enhanced um, uh, infection, whatever risk allowance, because also some people pick up very bad dermatitis because you are supposed to clean yourself with 0.05% chlorine water. So, I mean, those are the issues you need to be compiling together, and you also be on the table as they discuss where. I've told you where you select to send the quarantine center must take note of the fauna and the flora that would support animals that form as reservoirs. It's not just exposing nurses, and this is basically what I wanted to say. So one of my biggest fears, why they are not doing this, do we know whether the new so-called Bujibujo virus is a Creole virus, but actually a laboratory made to come and destroy people? Please let me not add any more. Anybody with
So can I ask
reaction, make
can I
reaction.
ask a
I'll be
question?
available for answers later. Question and answer later. I'm not going to be listening to the
So,
other briefs.
just
Yes, please.
Alice. So, thank you so much, Prof, for the session. So, Alice, just write down your question, and also you're going to give a time for questions and answers. So, at this
Okay.
point, I'm going to invite the next speaker, so that now we can. You may also have another question for the next speaker, so that now we can put them together. So, our next
Okay.
speaker is Mr. Christopher Kibiwott, OGW. He's going to talk to us on in terms of disaster management, because these are multi-sectoral practices. So he has trained in Israel, and he's going to talk to us about biological disaster and how we need to be prepared for this session. Thank you so much, and welcome, Mr. Christopher.
Thank you for so much, Silvester Owenda. I'm glad to be in this meeting today. And thank you, Prof. You have actually hit the nail on the head in terms of what this Ebola is, the mode of transmission, and the risk which we as healthcare workers would be facing in case it crosses the border to this country. So for me, I'm going to just delve into what actually we need to do as a country in terms of disaster management in case of a biological incident, like now the Ebola Virus Disease. The first thing which you need to have heard, and actually we should be domiciled, I don't know, I think in Kenya it is domiciled in Disaster Management Committee or National Disaster Management Unit, I don't know what it is called, but it seems maybe it's not moving. Number one, what you need to do, those are the principles of disaster management. Because remember, Ebola now is just an outbreak, and it has become a pandemic. If it is not managed well, it will become a disaster if it spreads to other areas. If we don't manage it well, if we don't manage the disaster well, it will become a crisis. And when we talk of a crisis, it is when systems have failed and we cannot be able to control it. So number one, in terms of hierarchy of disaster management in case of a biological event, is to have an incident management system. We have to establish a centralized incident management system to coordinate rapid response teams, map logistics, and manage resources efficiently. Do we have that? I don't know. Maybe it is in the Ministry of Health, maybe it is in the Ministry of Defense, I don't know. But as far as we know right now, we have no direction. We are hearing communication coming from all over. We don't have a centralized command system, which could be a really dangerous thing if Ebola actually happens to come to the country. This command system is supposed to be working from the top with all the resources and with capability of reaching every corner of this country, including the cross-border collaboration. Actually, that incident command management system should actually be in touch with Uganda, DRC, and giving us real-time data every day. Not only real-time data, including communication on how many people have crossed the border from DRC and where are they. We need them to be mapped so that we are supposed to be being vigilant about it. The second principle in this situation is surveillance and contact tracing. When the incident command hierarchy has identified that we could be having suspects, we could be having contacts. And actually that one should be every day discussed at the headquarters. What do we do about surveillance and contact tracing? We need to have people on the ground doing the case finding. Unfortunately, these days we have the county government, which seems to be disjointed. You might find County A is doing very well in terms of public health, County B is doing nothing. So if we had a central command, it could be very easy for us to say, in every county, we have people from the provincial, from the county level, all the way to the villages, so that they can be able to say, so and so traveled to DRC, so and so was in Uganda. We don't want to victimize anyone. We just advise them to self-observe in case there is any small symptom corresponding Ebola. They can just report to the next facility. The same unit, surveillance unit, is supposed to contact monitoring and actually observe those people, whoever has crossed the border from Uganda, from DRC, for a period of 21 days. And here, observing does not mean necessarily putting them in a quarantine place, because in Ebola, you are only infectious when you are in the wet phase. You are having the diarrhea, you are coughing, you are sneezing, and all that. Unfortunately, by the way, the Ebola could mimic many other conditions. So we need to do that test within. Actually, they say after the onset of the symptoms, it will take about 72 hours for you to detect the virus in blood. So there is a window which we could miss. Actually, if we do the test early, we are likely to give somebody a false negative and they go back to the community and spread. So that's why we have the 21 days window. Number three, the principle we are dealing with biological hazards like Ebola is infection prevention and control measures. And I'm happy that Prof has handled infection and prevention control measures very well. This includes screening and triage. We have to implement strict triage system in our healthcare system. And we are not talking about healthcare systems like Kenyatta National Hospital. Actually, it should start from the source. Those hospitals at the border, the dispensaries at the border. We need to initiate those triage, because remember, Ebola can just get a small weak link in a support staff in a health center somewhere, and it will expose the whole country. So we are supposed to train the nurses or the clinical officers who are seeing these patients to be able to identify the case definition that could fit this Ebola and do quick triage and make sure that they go to the correct place. If they don't have Ebola, they just go through the normal system after the tests. And if they have, we need to set up an Ebola isolation unit. And by the way, there is a principle which is very important when it comes to managing pandemics and outbreaks. We don't need to move a patient from Busia all the way to Nairobi. We should set up facilities, quarantine, isolation facilities along the border. Namanga, we should have one. At the Busia, we should have one. We actually moving that patient from one point to the other is exposing the entire country. Can you imagine you put a patient in an ambulance who you suspect or who could be having real clinical signs of Ebola? Tell them, oh, you do this, can we go to KNH? Because that is where you have a center. You are infecting people across the road. So the principle is that we need to set up isolation facilities where the incident happens. The hierarchy of management, somebody is making me mute. The hierarchy of management is we only transfer patients to a higher level of facility if they need specialized care. Maybe they need ventilation and all that. But in our case, we always, if we had a good incident command system, we should be able to provide those facilities at those border point levels so that we don't get them coming to Kenya. Then personal protective equipment is still part of the infection prevention control unit. Equip the frontline healthcare workers with mandated PPE. And this is very important. In public health, we call these frontline healthcare workers as a ring of protection. Ring of protection means we don't want the Ebola to slip from them to come to the rest of the population. So if you don't provide them with the PPEs, surely what will happen to the rest of the country? So we need to equip those guys from that level. And actually, the PPE includes just as much for those people who will be handling the wet faces. We need to train them how to do the donning and doffing. And that one, all that actually should be done by the command, the incident command. And by now, actually, by the time even there was reports of the the Ebola in DRC, we should have started activating the system slowly, because as per now, we are not prepared to handle it, because the people we are called experts, the ones who participated in Ebola management in West Africa. Most of them have retired. Most of them have left to the US. So the people we have actually need refresher training, because actually we are looking at the people who have been to those areas, and they also like we need a refresher training for at least 5 days before you tell us to manage any patient. So PP is very important. Then within the IPC, environmental safety, we need to make sure that we have a good flow, even in that small health facility. We need to have a triage area. That is point number one. If you have symptoms corresponding to Ebola, you go left to a waiting facility, and actually you are given a bed to rest there, and you are told, by the way, we have seen 1 to 3. You think we need to give you for to keep you for observation. If there is no symptom, they go to the right and follow the normal process. Because remember, these patients come to hospital. They could be coming to the liver, be coming for heart conditions. They could be coming because of renal issues. We don't need to stop other cases. What we just need is that vigilance at the triage area. So environmental safety means the flow should be very well mapped. Number two, cleanliness. Actually, the best cleaning material so far actually is sodium hypochlorite, correctly reconstituted, 0.5% for environment and 0.05 for hygiene. So training for the healthcare people. Then number four, a good principle is safe and dignified burials, because eventually you heard Prof saying that the case fatality rate could be as high as 50%. The Zaire and Sudan species were actually giving us mortality of almost 100. So we need to also teach our people about safe and dignified burial, putting risk mitigations in place. As it is now, Ebola, we know to some extent that it is not a droplet, it's not airborne. But what we know is that it is contact with body fluids and even contact to the patient. Because remember, there was a nurse and a driver in Uganda who got Ebola. We don't know at what point the driver got Ebola. Was it just by assisting the nurse to leave the patient? Or is it that he breathed the same air with the patient? So those are the things we are not sure of. And that is why when you talk about handling Ebola, we need the full bodysuit. So we need to have the risk mitigation. And one of the most important principles when it comes to handling bodies of a dead Ebola victim is that the patient should be bagged immediately. And then the exterior part of the bag should be decontaminated with sodium hypochlorite thoroughly. We should not remove any invasives. We just put the body the way it is. And burial should be done immediately. We don't pass this body through the mortuary. So actually the relatives should be communicated that way so that they understand the situation. Risk communication and community engagement. These are very important issues when you are dealing with a pandemic or a deadly disease like Ebola. Just talk to the locals. Localize the messaging. Tell them through their vernacular radio stations that these are the symptoms. You can get it through 1 to 3. And these are the mitigations you need to put in place to make sure that you are safe. When you tell people that, you will reduce stigma, you will reduce the fear, and you will actually be able to get compliance. They can be able to say, hey, bro, I went to DRC, or I went to Uganda, so I'm coming for you to check me. Otherwise, if we keep quiet, people are just hearing from reading on social media that it is killing people, it is 100% mortality, it is in Kenya. You see, that fear will actually make people to be uncooperative. Remember, in DRC, there are people who went to a Ebola treatment center and burnt it. Why? Possibly the communication which was there was very poor. Nobody told the people why they are putting their people in those centers. So that is very important. And to make sure that we eliminate that stigma, we reduce the stigma, we engage the counselors, we engage the community health workers, we engage the professional administration to make sure that everybody understands that Ebola is a disease like any other, only that this one is a bit deadly and not very well understood. Then number 6, as a principle of during the disaster management, is case management and continuity of care. In Ebola, the standard is so long as it has been confirmed or the symptoms are there and the epidemiological link is there, they must be nursed or managed in isolation units, which I said we avoid transferring the patient for a long distance. Right now, if we had a good incident command, we should have set up an Ebola center at the borders. And by the way, to set up an Ebola center does not need a lot of resources. For those who went to West Africa, they were using tents, just a very big tent with good demarcation, good air system, good airflow, and correct marked traffic areas. It can happen. So case management, so such patients should be managed in isolation units, preferably on room with all the amenities available. When the nurses go to take care of the cases, they need to be, always say you work in pairs and you have a supervisor who will be monitoring you from far to make sure that there is nothing you miss. And during a case management situation, there is no doctor, no consultant, no nurse, no support staff. Because remember, you can contaminate yourself if you neglect the support staff, because you will be taking tea together later. So in case management, you make sure that you do one round. If you do feeding, you do medication, you do suction if there is need to be done, you do whatever you need to do, and you come out as a team. Doctor, nurse, support staff, whoever goes there. There is nothing like hierarchy there. I'm a consultant, so I don't need to go there. I'm a consultant, so I should be having priority. No, in case management, we need to work in harmony, because as we say, the weakest link is the one which can make can put us down. So we make sure that everybody is taken care of. So essential services like deliveries and all that should continue in that health facility. And we always prefer, if you have an Ebola facility in an area, it should be a bit isolated from the real hospital, so that there is good flow, and actually we reduce the stigma again. And we have very clear markings to say that there is a controlled area where nobody else should be going. So in terms of disaster management in cases of Ebola, I think that those are the principles we need to adhere to at any given level. Even if you are called for a meeting, these are the issues you need to raise. Start with command system, which is lacking. In fact, we don't have a command system currently. You will hear when we get one Ebola case, that is when you will now realize that things are not working very well. So thank you. Back to Silvester. I'll get questions later.
Thank you so much, Mr. Kibiwott. That was a great one. So on the last part of it, I'll just mention a few things that you need to know in terms of the body handling in the forensic side of it. So one of the things that happens when someone dies is basically the cells begin to break down. So at that point, basically, we normally have a lot of fluids coming from the patient, from the body. So you don't need to handle that body the way we have been handling other bodies. You're turning the body left and right and center. So basically, you don't need to do that, because at that point, basically, those fluids are the ones that are going to transmit this infection. Also, you don't need to embalm the body. So basically, the way Mr. Christopher has just said, you need to put the patient in double bags that are leak-proof. So these bags should not be leaking. So basically, you don't need also to embal these bodies. That basically means that these bodies should not go for the mortuary or for refrigeration, preservation. Another thing that you need to do is you do not perform any autopsy when it comes to that point. So do not perform any autopsy and do not collect any sample. If the patient died with the NG tube or the patient died with any invasives, please do not remove those invasives. Then the last thing that I can say is that if you have a person who has died, who has epidemiological link, a non-death or abrupt death, please treat that body as a positive case. Up to that point, I think I'm going to hand it, give the next person. Let me see if the next person is in before we go for questions. Let me see. Mr. Dan is in another meeting as we speak. But I have another person here. Let me see if the person is in. So we have one of the team members who also accompanied Mr. Dan to West Africa. Though she's a retired senior citizen, I want to welcome her, Lucy Kanyi, to share with us the experience that was there and how they managed to come back, because I know very well that some of the healthcare workers who went to West Africa did not manage to come back. So Lucy Kanyi, welcome, and share with us a small bit of what was there. Thank you.
Thank you very much, Silvester. Good evening, everybody, and how are you doing? As you have heard, my name is Lucy Kanyi, a senior citizen, retired 2 weeks ago, and enjoying my retirement. Now, about Ebola. As you have all been told, it is a very dangerous disease. One case is actually very, 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 very sensitive. And when you hear there is one case in Kenya, then it means there are many more who may be out there. When we went down to Liberia, I went to like 6 months to go and fight Ebola. I know everybody will be like, how did you get the guts to go there? It is just enough to do is to ensure that you have followed up all the infection prevention and control measures that have been put in place. So we would go to West Africa. The first thing they would do is to ensure that they have trained you on what is expected of you and how you should behave when you're in the community, when you're in the hospital. And after that, they would release you out to the counties where we were going to be able to stand up and teach the community, teach the hospital staff, and help in management of the Ebola Virus Disease. I was posted to a county that was interior, many, many kilometers from the CBD. And that is where I was meant to go and manage the Ebola. All you need to do is to ensure that all staff are at par. So my responsibility was to sensitize staffs in the whole county. I would make a plan for each health facility where we would go as a team. You do not go as an individual. You always go as a team of multidisciplinary staff. As Kibiwott has said, even when you're going in to take care of the patients, you have to go in as a multidisciplinary staff, or the people who are going in, whether it is a nurse and the support staff, a nurse and a doctor. The people who are going to go in are the ones who are going to ensure that they have done all the procedures that are required to be done on a patient so that you do not expose many people. So people have to go in as buddies. And before you dress up, you also dress up as buddies to ensure that every part of your body is covered so that you do not expose each other. And the aim of being in as a group or buddies is to be able to look out for each other so that in case something happens to the one person in, then they are able to call in the another staff. Once you would suspect that you have been exposed, the best you do is to inform your colleague and you leave, and you must go and doff. And the doffing system also had to be inspected by somebody, and you would do it very carefully, because one small tiny mistake can actually make you contract Ebola. Like you have heard, it is from contact and it is from body fluid. We managed to go, as long as you have followed all the procedures that are supposed to be followed in doffing and in donning fast and in doffing, then you will be safe. So there's no need of fearing when you're going to take care of Ebola patients. It is very, yes, I know it is scaring. That is the word. It is very scary. But we managed to take care of the community. We managed to take care of the hospital. And all the time, for the 6 months I was there is no staff who passed away, and there was no Ebola patient who passed away at that point in time. Because all you need to do is ensure that you have also done for them the best that you can be able to do for them. And after every 8 weeks, you were required to take a break, which is very important. You cannot be able to go through months without taking a break, since it is very stressful. You also need time out, because if you take care of the Ebola patients when you're stressed, then it is very likely that you shall expose yourself. It was very nice. It was also very challenging, because some of the things that you're teaching them not to do, like not eating the bushmeat, you would actually, on your way out, even in the hospital compound or just outside the hospital compound or in the community, you'd still find that they are selling the same bushmeat that you're telling them not to. So my last word to you, it is just being careful. As long as you follow all the steps in donning, in doffing, take care of each other as buddies, and you do not try to, like, let's say when you find that your glove has gotten torn, and you decide, let me just finish what I am doing, that is one of the greatest mistakes that you can do. Because once one glove is torn, then you could likely be exposed. So when you follow all the procedures, you follow all the laid down donning and doffing steps, then you will be very safe. I am safe. And even now today, if I am called upon to go and take care of Ebola patients, I will. It's actually very interesting. Let me tell you, it's always very good to give yourself a challenge. I went 6 months. People like Daniel Were were there for 1 year, and we came back safe, because we took care of ourselves, we took care of our colleagues, we took care of the community, and we took care of the hospital staff. So when you're called upon, please just give yourself in, believe in yourself, and always say, I can do it and I can make it. And that is how I did it. And even if I am called upon today, I will still do it. Thank you very much. Back to you, Silvester.
Thank you so much. Thank you so much, Kani. That was a great experience that we had. So team, enjoy, Lucy, Kani, enjoy your retirement, and we might look for you very soon to come and help us with the experience.
Thank you.
So the team members, kindly put down your questions, as we are going to start answering the questions one by one. So my first question, Professor Joseph, are you still there?
Yes, I am.
Thank you. Question number 1 goes to you. What is the difference between the various strains in terms of virulence and infectivity?
I answer immediately.
Yes, just answer.
Budibujo is a much more severe strain. I don't say it's the latest. Uganda did very well, so we kind of used the Uganda data. The Sudanese strain was considered to average up to about 80. Uganda brought it to about 60%. Budibujo was surpassed back to 70-80% death rate. And for now, the one that we do not understand because we've not been given its molecular characterization, we are not able to vouch whether it is milder or worse. And also the data coming from DRC currently is not very strong. Thank you.
Thank you so much. That is a good one. So the next question, basically,
Yes,
next question.
sir.
Yes.
Can I interrupt?
Okay.
Yes. Okay. I'm not unable to put the question down, but can I ask the question? My question is,
Okay.
what is the incubation period of the Ebola now?
Okay.
Yeah.
Professor, you can just answer that.
Yeah, incubation period has not changed. It is still 2 days to 21 days. 2 days to 21 being the long range. The model period is seen to be between 8 and 12 days. More often than not, they say after the 12th day, there are very few people you'll detect, but there are still some that show signs and symptoms. However, it has now been also established that even much longer, up to 3 months, somebody can still be infectious when the Ebola virus has gone to hide into certain glands in the body, especially the lymph glands and also the gonads. I hope I've made it clear.
Yes. Next question, I think Mr. Christopher, you tackled this very well, but you can still just give a short one. So even with the courts having stopped the establishment of an international quarantine center in Kenya, we are still exposed based on our proximity with Uganda. So the question is, what preparedness action should be put in place? Mr. Christopher?
So thank you, Silvester. So the preparedness which we just need is being vigilant at the border. And vigilance does not mean somebody just using a gun thermometer and shooting it on people as they pass. Within 1 second, they're done. It should be real screening, whereby there is a form everybody needs to fill, including where they were, what their business was, if they had any condition before they left for Uganda, and what they are feeling and all that. So that is a real screening, not necessarily just taking the temperature. History will actually help us in getting that epidemiological link. Somebody could have traveled to Uganda just across the border, or somebody else could have traveled all the way. And actually we need to look for evidence, maybe even in the passport, to see whether that person actually was only, somebody can lie that they were in Uganda, yet they were in DRC. So the screening is actually the most important part to make as a first preventive measure. It is what we call in hierarchy of IPC elimination. We make sure that we don't get any cases imported to the country. So that is what we need to do at the border level. When we talk about that, like TPO thing, I don't know the logistics. I don't know how we reached it, but anyway, that one is being handled by the government at that high level. But I don't know how far that thing is and how far it is going to affect us. Thank you, Silvester.
Thank you so much, Mr. Chris.
Silvester, I want to
Yes.
make a right on the cross-border surveillance.
Okay.
In cross-border surveillance, we say we have 3 distinct populations. Population 1 are the locally resident people, and they don't move. Usually those never get affected. Now we have another group called they are shuttlers. They are the ones every day they wake up and go to the other country, and others coming this way and evening they'll return. And those also are less risky. The most risky population are those who intermittently visit the border point, and they use those crisscrossers to be able to smuggle goods that ordinary people would not need or you have no problem with. And those are the ones who are at risk because when they are waiting for their shuttlers, they seek entertainment services without knowing the risk factors. As my brother had just answered, The passport may not show you the activities because when you just get to that particular border point, you don't have business. When you're inside that country, the country, you do not keep stamping the passport. It is just their goodwill, but using local surveillance teams, those people who now know who is the shuttle of goods, who does what, who disappears to the other country, who comes back, you will know what interaction somebody had and decide whether you can quarantine them at the border point before, release them into the country, or alert the inside country teams that this guy is a suspect. But then even shuttling them in the via bus could also be a risk. Then that decision is taken at that level. Thank you.
Thank you so much. Thank you so much, Prof. There's a hand raised by Paramedic Association of Kenya. So let's appreciate Let's Talk Nursing for organizing this session to empower the healthcare professions, not just nurses alone, but everyone that is involved in the care of our patients across the country and also across the borders. So thank you so much, Let's Talk Nursing, and keep doing the work. So before I go to the next question, I'll just request the Paramedic Association of Kenya to give us, ask their question. Yes, Paramedic?
Thank you, Silvester, for this opportunity. Maybe my question would go to Mr. Dan Were. I understand that he was on the ground during the West Africa outbreak. So my question to him, what was the biggest mistake made in the first weeks that pre-hospital and frontline health workers paid for later? And what is the one thing Kenya must do differently right now before a confirmed case arrives? And maybe my last question to Professor Joseph Njau. Kenya has 22 designated high-risk counties, one confirmed viral hemorrhagic fever isolation unit at KNH Nairobi, and a pre-hospital workforce that has received no published national protocol for a suspected Ebola case. So in your professional assessment, is Kenya operationally prepared at the frontline level or only administratively prepared at the national level? Thank
you. Thank you so much. Let's start with Mr. Dan Were is not in, but being that Lucy Kanye is still in, she can respond on this, some of the mistakes or challenges that they faced and what Kenya needs to do and what Kenya needs not to do as we prepare for this.
Thank you, Silvester. The most important thing is to ensure that all the staffs who are going to be in the front line, they are well trained, they are well prepared to go for it, because when you send staffs that have been forced to go to be frontliners, then they have gone out with stress. And so it is very possible for them to make very small mistakes that can actually expose them to the virus. So it is very important that by the time maybe we are getting the first case, if we shall, is to ensure that staffs who have been trained have been taken through a drill to be sure that whatever they have learned, they are actually really ready. There must be theory and practicals that have to be carried out as you are preparing the staffs to be frontliners to take care of the Ebola victims. For us, it was, we actually were getting 1 week training. When we learned, you'd be allocated into, you'd first go to Brazzaville, Congo, where the orientation would take place for a whole week before you report to the country that you're going to, and then you're posted. Then they are sure, by the time they're posting you to the counties, they are sure that you are actually really prepared, because when they are taking you through what is expected of you, they will ask you questions, and they will need you to ask questions where you have not been, you have not understood. So they will make sure that you are prepared psychologically, and physically, and you are prepared with the knowledge to be able to go and take care of the community, the hospital staff, and also the victims of the Ebola virus. So it's very important, even in Kenya, that when we are taking our staff through training, let it be both physical, let it be physical, there has to be theory and practicals, and let all of them go through the practical part, especially the donning and the doping, because that is where the greatest mistakes come in. Thank you.
Thank you so much.
So
Lukman,
Silvester, maybe I
kindly.
may add. I may add something.
Okay.
On top
Lukman,
of what,
kindly unmute. Kindly mute. Lukman. Lukman, kindly mute. Yes, Mr. Christopher.
Okay, I wanted to add some of the weak points include delayed detection. That is because of poor surveillance, which I think that is a problem which can also afflict us as a country. Weak surveillance system. Then we have the slow response. Since the Ebola crossed to Uganda, the response has been low, and there is insufficient funding. As early as even last week, there was no funding. People are just talking about the money is available, we are ready, but in reality, they are not. Then we have a lack of PPE at the frontline areas, which is also another dangerous thing I just talked about. We have unsafe traditional burial practices, which could actually spread the Ebola without us knowing. And then there is another very important thing which I mentioned, lack of community engagement. In West Africa, we saw people being forced by armed policemen to go to some isolation camps. When you force the public, they will run to the bush and hide. And that one is not a good thing to do. And in Kenya, we don't want to get into that situation whereby we start forcing people to quarantine, even if they don't have a clear epidemiological link. That is a thing we need to also learn. Then we have the logistical mistakes, supply chains. Right now, I don't know how many hazmat suits we have in the country. I know it is there are very few. In KNH, we don't even have enough. Then we have the poor coordination of among the responders. NGOs, government, and some associations are speaking at cross purposes. We are not speaking in the same language. And then we have the clinical management errors which might occur, delayed tests, haphazard deployment of staff, even the ones who have not been trained. Those are the errors, the mistakes which might be made in our country. Thank you. That was my addition.
Thank you so much, Mr. Chris, for the addition. Professor Joseph, you can pick on your question.
Yeah, I just want to say that when I was at the ministry, I'm aware that there are quite a bit of elaborate documents. Unfortunately, they're not very well bundled for purpose of training. People that they are just happy to be called for per diem. They run and they have not completely put a guideline. This is the way you will manage Ebola when it comes. When it was last revised, there are a couple of changes that I know have happened and are still being cited as the rule of the thumb. Yeah, that is a big weakness. And just as like the guy who just contributed now, he's completely right that even we do not. There's even a time I actually give guidelines, the duration, the work schedule for people who are in isolation, factoring their physiological changes because of the heat, looking at how much they should be hydrated, putting where the kind of fluids that should be waiting for them immediately they doff the PPEs and all those kind of things. But all those things, I know they are no longer together because people want to keep throwing away so that the next time they are called for into these jobs where they're given allowances to do. But I think the nurses association, other professional association should be able to provide leadership now so that they very jealously guard those documents, and we do not have to go back to the repeat every day like it's been mentioned here. And just like Lucy mentioned, then you know people you've sent for a real theoretical training and also given them, even if you don't have a real Ebola, they do a role play. As They simulate a scenario like a real cases there. And they do it with a health worker who will say, I think you mismanaged me, 1, 2, 3. And that is all learning, not complain. And we help each other. And the person complaining is the one who's going to be doing a mock duty on the person who they say failed. And let's see how they will also make it. I totally agree. But and again, professional associations don't solicit for funding to put these documents in place. In the US, the American Nurses Association is a provider of, is a technical leader in that field. And we could do exactly like that. Thank you, sir.
Thank you so much for that a good response for the team. So Let's Talk Nursing basically is a nursing platform that brings all nurses across to share ideas, sharpen themselves. And today's platform, we have presenters. That is Professor Njau, who is also a nurse and has worked with the Ministry of Health and Department of Communicable Diseases and Surveillance. We have Mr. Christopher Kibiwott, who has a background in nursing also. He has specialized in infection prevention and control and also disaster management. We have Lucy Kanyi, who has just spoken. She has specialized in neonatology nursing and infection prevention and control, who went to support West Africa. And I'm speaking with you here. Also, I'm a nurse, Silvester. I've just specialized in infection prevention and control and forensic medical examination. So we are nurses who are speaking here, but we don't limit our platform for nurses, for other cadres. So we also welcome other cadres, and we shall continue having the same sessions as we move on. So we are moving to the next session, the next question. Before we move to that session, if you look at your chat box, Mr. Leonard Otieno, who is the team lead for the Let's Talk Nursing, has just posted a WhatsApp link so that now if you want to join the WhatsApp group or channel, you can join through that link for further communications. Thank you so much for joining Let's Talk Nursing, and to the next question plus remark. So Ms. Linda is saying PPE is important, but in terms of Ebola, it's ranked at stage 4. So isolation is the most top priority of the curbing and reducing transmission. My question, why are we talking about getting suspected cases being brought into the country rather than enduring that they get quarantined at the source, that is DRC? That is question number 1. The question number 2, do we have a command system? I think Mr. Kibiwott had talked about this. He responded to this very well. We don't know the relationship between the Kenyan government and the US government in terms of bringing the patients who the suspected cases for quarantine in Kenya. And where Mr. Christopher also, in terms of disaster management, he clearly said that we really don't have that straight command system at place as we speak right now. So as we move on, we'll basically know whether we'll have that command system or not. Then this one also, I think, has been tackled somewhere, but not directly. So basically, this one will be tackled by Professor Joseph. Do rural border clinics have on-site incinerators capable to reaching the highest temperatures needed to destroy Ebola biowaste? So Professor Joseph, do rural border clinics have on-site incinerators capable of reaching the highest temperatures needed to destroy Ebola biowaste? Sorry.
Thank you very much for that question. I was the architect for the country's Ebola contingency plan, and because we don't have those incinerators, I had provided for a mechanism where all the waste would be haulaged or carried away to safer place where they would do the necessary incineration. What involves, like what happens in the US, they contract companies, and that's why I made the provision for that in our contingency plan, is to get pre-qualified companies that will man certain regions, and then they would calculate the volumes in terms of production and how long you should keep it intact. Then you haul it to another place where then it will be incinerated under inspection, and that's what we could do, because if we must be able to decentralize how where we take care of Ebola patients. The other thing was that emerged was a big challenge was burial sites. As Mr. Kibiwott mentioned, yes, you should not keep dead bodies, but again, you cannot bury them where there's no public land. Like we went to Busia, and there was basically no public cemetery. So I had been asked to make sure that I don't leave the place without identifying a place where we could isolate and also bury. So I went and did some the things I was supposed to do very well. Nobody knew what I was doing. In fact, one of my team members was saying, "Well, what are we this kind of questions? We're asking questions about goats in an agricultural institute." And we basically advanced. I replanned how humanitarian logistics, the place will be converted into an Ebola isolation, and a grave where you bury Ebola bodies remain under police guard for 15 years when you expect the virus to have completely disappeared. So that's why I had to identify some land which had not been earmarked. Up to now, the regulations don't require that any county considered high risk to have a possible Ebola graveyard, not for other dead bodies. I also want to mention WHO has since said when you have highly infectious diseases like COVID, Ebola, and all these, nurses must not do last offices. I repeat, nurses must not be involved in last offices because the nature of training converts nurses to be very massive people, and they might jump into CPR for a person when they have just been resuscitating. Yes, they will revive the person, but then will die of the actual more severe disease. So nurses should not do last offices, and that is a global standard now. I don't know whether it's been customized by the local guidelines and regulations. Thank you.
Thank you so much. Keep on raising your hand. I am seeing you. We are moving there. So another question that Prof will just talk about.
The cost of goods and services.
Okay. So if you join, kindly, when you're joining Let's Talk Nursing platform, this session, kindly mute and switch off your video. Videos may basically normally interrupt some sessions. So we don't know what is happening on the background, please. We don't want to know those things, kindly. So Prof, there's a question about signs and symptoms and clinical management, and if there is any specific treatment. This is back to you.
Most cases of Ebola or all the viral hemorrhagic fever, especially Marburg, is also a cousin to Ebola. It's also a filoviridae. A lot of them in Uganda have all emerged from the Queen Elizabeth National Park, and again also the caves of Mount Elgon. Now, they all start with a kind of a sore throat, and then general weakness before fever begins to rise, and that leads now to more severe inflammatory response across the body, and then the body begins to become weak and very prostrate. In some situations, diarrhea is also a very prevalent thing because it causes like irritable bowel syndrome, and so they start having diarrhea. Then when they get a bit acidotic, then that's when you will see vomiting. But generally in that, then it gets into the blood where it causes the coagulopathy and begin to see bleeding under the skin. After you crush the hand, like when you are trying to help a patient, it gets a chemosis, and then you see the hemorrhaging tendency. And hemorrhaging tendency is towards the end, and a very, very ominous sign. So I hope I've covered the sensory symptoms very well. Thank you.
Thank you so much. And at that point also, we have to note that we still don't have any vaccine for the new strain that is Bundibujovirus. So basically, we still don't have a vaccine for it. There's a comment here that everyone needs to listen to. We want to see the actualization of command centers and robust disaster management system before we are caught unaware. We have a grace period to enhance public awareness, so it becomes easy for the affected families to understand how to handle a suspected case and even after demise of an Ebola patient. So basically, that's a point also to note. Incubation period, basically, Prof had talked about, and we also talked about signs and symptoms, and also in exposure. There's another question here. As a straight point, can isolation centers set up during COVID times be used for EVD preparedness? So I think, Mr. Chris, you can answer this because I am very sure you visited some of the sites of late. So Mr. Christopher?
Yeah, thank you, Silvester. Yes, the isolation centers used for COVID-19 can still be used for Ebola, only that we need to do some slight modification because COVID was droplet mostly, and Ebola is now contact. And actually, Ebola has not been understood very well. We just say it is contact, but there are people who get the disease even when they have not been actually in touch with the patient. So yes, we can use the isolation facilities which were there for COVID. We just need to reactivate them and make changes here and there. Thank you.
Thank you so much. Thank you so much. There is a question here that we'll ask Ganyi later. There's a question here that states that define the procedure for donning and doffing. From the IPC side, Mr. Christopher. And I think donning and doffing also, you need to mention that they don't happen at the one point. They happen in totally two different points. So, Mr. Chris?
Okay, I can try to just talk about it, but the best is actually when you are visually able to see it. But let me start by saying this. Let me start with the donning. Before you don, what you are supposed to do is make sure that you have emptied your bladder, you are comfortable, you don't have anything disturbing you. Remove watches, remove bracelets. If you have long hair, make sure it is tied very well to your back. That is for the ladies. That is number one. Then, when you start the process of donning, remember, we said we work in buddy system. So you are two nurses or a doctor and a nurse, or a doctor, nurse, and a support staff. There must be a fourth person supervising you so that you don't miss any step. So that person must be there. We call them the monitor. We start by putting on the footwear. In most cases, it is the gumboots. Then after the footwear, what you do next? By the way, I forgot to talk about hand hygiene. That is very important before you start doing anything. Then you inspect your hazmat suit. You must get the correct size, not too large. Too large can be able to expose you because you will be dragging everything. Too small will make you very uncomfortable when you are working, and there is a danger of it doing what? Ripping apart. So you usually start with the footwear. Then you put on the full hazmat suit, which is usually, it is designed in such a way that it actually covers everything from your boots all the way to the head. So what you do, you step into the two legs. Each leg goes to the leg of the hazmat suit. Then you insert your hands. Then you zip it with one move. That way you have done your hazmat suit. So the next is to put on the first layer of gloves. Here we only use sterile gloves. And this first glove is it will never come out. It will just come out when you do the doffing. This will act like your hand. That one never comes off. When you put it on, you make sure that in the hazmat suit, you have made a puncture so that the thumb can get in before you put on your glove. Then after you have done that, put on the N95 mask. And when you are putting on the N95 mask, make sure that the two straps, one goes below the ear, the other one goes above the ear. There is no crisscrossing at any given time. Make sure you pinch the nose, the nose ring, to make sure that can clip at the nose, to ensure that it is well fitted in your mouth and the nose. Do a test to make sure that there is no air coming into your nose from outside, so that every air you breathe will be filtered through the N95. And the best N95 mask is the one with a valve. I know there are differentials which are here these days, which do not have the valve. The valve acts as, when you breathe out, it opens. When you breathe in, it locks. So the best is the one with the valve. But even if you have the other one, there is no problem. You can just make sure you test to make sure that you are not breathing air from the environment. Then from there, you come with the goggles or the face shield. You put on in most cases, we have the goggles. Put on the goggles and make sure that the straps are also not crisscrossing anywhere. From there, you remember the hood. Now the hood covers your head completely and it is zipped. That is when now you need to wear your second pair of gloves. The second pair of gloves is the one you will keep interchanging. Whenever you do a procedure, you remove the outer layer of gloves and you put it on another outer layer. Remember what I said from the beginning. The inner layer is like your hand. So that one will never come off until you are done. So let me mention the weak points of the asthma suit, which people need to be very conversant with. The first weak point is the zip. The zip is actually, we don't have full protection. So the mitigation for that is that you need to put on an apron. That's why at the end of it, you put on the plastic apron to make sure that it protects your front part and to protect any spill which might come to you. The other weak part is usually the gloves, where the gloves end. That's why we say your thumb must actually be, you puncture the, at the seam level, you puncture the hazmat suit and make sure that your thumb is overlaid so that it will never go up whatever procedure you do. Those are the two weak points. And the other weak point, which has been eliminated by making sure that you have an hazmat suit which covers from head to toe, it could have been when you have gumboots and then you have an hazmat suit you need to tuck in. So that one has been eliminated. So that those are the areas you need to note. Then after that, there is supposed to be a mirror. You check yourself in the mirror and make sure there is no place which is left. At the same time, the person who is monitoring you also gives you a thumbs up. And at the end of it, your name is written so that we should be able to know whom we are addressing when they are in the treatment area. And as I said before, we work in buddy system. So when you go in, you do the procedure, all the procedures at once, so that there is no need of going back and forth. Then you do your procedures, maybe bed making, treatment, giving the patient tea, changing fluids, and all that. You go systematically. And whatever, as I said before, what you need to change is only the outer pair of gloves. You dispose it properly in red liner bags, which are well labeled. And then remember, every time you remove the outer glove, make sure you perform hand hygiene using 0.05 sodium hypochlorite. Then you have done your procedures, and it's now time to do the doffing. What do we do during the doffing? You come, there is a red line where across it there is a public health officer plus your supervisor again, making sure that you doff safely. And I must say that this is where the problem of infecting yourself happens, during the doffing. By that time, you are tired, your concentration is very low, and you are in a hurry. So actually, we always say when you are in a IDU facility, don't be in a hurry in this world. Just relax, take your time, because actually the cost of being in a hurry can be disastrous. So you get to the doffing area, there must be a public health officer or an appointee who will spray you. Remember, when you are working in your clinical area, the dirty area or the contaminated area is usually below your umbilicals, because that is where the bed is, that is where most of your operations happen. So you are sprayed, with sodium hypochlorite 0.5%. Then after that, the first one to come off is we actually, when you are doffing, you remove the most contaminated first. You remove the apron by not removing it over your head. No, you cut the straps from behind with one motion, fold it forward and make it like a ball, then dispose. The next to go is supposed to be the hazmat suit. But every time when you do, before you start doing it, hand hygiene. When you remove, hand hygiene. So the next to go will be the hazmat suit. And how you start doing it? You flip back the hood, then with one stroke, and zip all the way to the groin area. Remove the hands, and then wiggle out of the suit until you are done with the foot. Now that is the time you remove your outer glove, then perform hand hygiene. By that time, you are a bit safer because you are now, whatever you are having now is your inner clothes, which are mostly maybe scrubs and all that. Then after you have done with the outer glove, you now start you remove the goggles. And how do you remove it? You flip the lower strap and bring it forward. Then you bring the upper strap and pull it away from your face in one motion. Then you discard. Perform hand hygiene. Then come, remove your N95 mask the same way. Start from the lower strap, then the upper strap, discard. From there, you now jump to the green zone with your boots. You cross that border. There is a bathtub waiting for you with your boots. Get into there, wash use the bathtub to clean the boots. And now you can step out of your boots into your waiting shoes or clogs or whatever. From there, you go to a washing area, perform that hand hygiene. You can put on your surgical mask, and you are now free to go to the green area. So I think I have tried to capture what you can do actually, but visually it could have been much better. But actually, exactly that is how it should be. Thank you, Silvester.
Thank you so much. Thank you so much. That was very great. And if there is any senior management team here, that is a director nursing services or nursing service managers in the team, basically you have been given a structural how your isolation site should be. And I think you are doing something with your leadership at the hospital so that now you can also keep the staff, the nursing staff at low risk and safe for further engagements. So I'll give two individuals some comments to give later, but I just want to tell you that to be ready. I'll give also Bridget Kagwiria. Please be ready with your small comment. You went to West Africa, and also Wilson Laela. You also went to West Africa, and you'll give us a comment. You went to Sierra Leone. Lucy Kanye went to Liberia, and I think you guys have different experiences in the two areas. So Kanye just received this. Wilson is saying, "Thank you, senior. I was in Sierra Leone. Again, I don't remember if our Kenyan contingent lost anyone of Ebola, specifically at Sierra Leone, where I was the team leader for Kenya for several months." So he also commenting and saying training should start in Kenya as soon as possible. So Wilson will give you a chance also to do a comment on how you did it in Sierra Leone. We have good testimonies around. Next question basically goes to Christopher and the Prof. I think this one has been clarified on the issues of airborne and contact. It has been clarified very well. Joy? Caro Polo, just mute, please. Sorry, you're a super mother. Happy Mother's Day. Then also we have a question here. Is there a difference in terms of severity of the disease among young and elderly population? Is it intense on those with comorbidities as it was with the COVID-19? Professor, what has the papers said about this? Because I know we have done so many papers concerning Ebola and COVID, and we have compared the two. Kindly respond to this.
Yes, all diseases generally are severest among the extremities of ages, the very young and the very old. And this is basically of the physiological capacity for the body to withstand severe stress, and infections are very severe. Comorbidities also complicate any infection because if somebody doesn't. Okay. So comorbidities tend to violate homeostasis, and the severe infection as well violates homeostasis. So those tend to be very severe patients, a patient that need close nursing care, but and also close monitoring so that you're able to detect those variations. Otherwise, it may be just inevitable. You might just have to lose the patient, not because you are not competent, but because of a couple of things like those happen. I did share I'm not sure whether it's Let's Talk Nursing or it's another one of the nursing forums, when somebody was talking about one of the hospitals that we should be glorifying, or that has become a death environment. And I asked whether isn't it time for the nursing governance structure, the nursing code essentially, to get together and begin to say, why would a civilian observe that and we don't seem to be doing anything? And yes, it is related to what you've asked, and that's why I'm bringing in there, because I'm a senior citizen as well, that we need to be able to appreciate that nurses, when they are strained, it reflects strongly on mortality level. I'm not saying nurses are bad. I'm only saying when the systems that they're made to work in are bad, mortalities are inevitable. But in terms of Ebola and even COVID, extremities of age were associated with a lot of mortality. Surprisingly, the babies were not very much at high risk of infection, but those that got were unable if you look at this age-specific death rate, then you would find that it was much higher than the general population. So that is exactly how it's measured in epidemiology. And it's just that we would like to keep those people a lot safer than get them exposed. Thank you. That's my comment.
Thank you so much. Thank you so much. Mr. Christopher, we have another question here that goes to you. A good point of coordination, Mr. Chris. I think the health cluster team under WHO should take a lead on coordination. So what's your take? Do we put it under WHO or do we put it under MOH? Because I think these are two different entities, but despite they normally work together. So Chris, can you respond to that?
Thank you, Silvester. I think there is usually an hierarchy here, which starts from WHO. It is permeated to the Ministry of Health. Then it is supposed to percolate down all the way to the smallest health centers. So if that one works well, we'll all be safe. So actually the structure of command, we usually borrow from the top to the bottom. I don't know whether I've answered that question well.
Yeah, it's home on my side.
Let me do a rider here. During the first Ebola preparedness that Kenya did during the 2002 outbreak in Uganda, was it 2002 or 2001? Actually, 2001. Tanzania had to ask their WR, the World Health Organization representative, to help them. And then the WR called the WR in Kenya and said he seems to be comfortable with what Kenya is doing. So they borrowed from Kenya a plan I had developed myself. And so eventually the rest of East Africa was like that. When we came under the threat of 2009 H1N1 pandemic, I was again a core team on the team that made Kenya's contingency plan. When our team, I was not involved, arrived in Thailand, they were cheated by Nigerians who did not have a plan and stole the Kenyan plan. So they were discovered by the presenters when they were presenting and party say, is Nigeria also having a part called Kenya or Nairobi? So they said, no, we forgot to change that. So that's actually how WHO. WHO also may not be on maybe among the top experts, but they borrow from countries that are doing well, and then they help other countries, because when we do the same thing and we do a good thing, the World Health is achieved. Thank you.
Thank you so much. Thank you so much. Thank you so much for that great presentation, that great input. So, Mr. Brian, kindly mute. Mr. Brian, kindly mute. So, this is a Let's Talk Nursing platform. Creates a platform for all healthcare workers, basically nurses, to sharpen each other, but it's not limited to, when it comes to presentation and sharing knowledge, it's not limited to nurses alone. It's open to other persons, other faculties, other cadres that can come in and also share information with us. So the next point is coming from Veronica. Veronica says, I am a clinical officer who was at the front line as an intern during COVID-19. Currently, I need to know guidelines for Ebola treatment. It's tricky when people is a challenge. Yeah. So basically, we really appreciate your work during that time. And we thank you, and we believe we are ready for this also. So the guidelines are coming up. We'll be posting them. Just keep on following up. We'll be posting the guidelines as they are going to be reviewed, and with the most current updates. So we'll be posting the guidelines. So Agnes, kindly, what's your question? Okay, Agnes knows there. So basically, Zedi, what they're saying, this great IPC infectious diseases course should be introduced to KMTC. So I can say not just KMTC, the sessions will be introduced to different healthcare training institutes, both KMTC and universities, so that now we can, the healthcare workers can know how they need to protect themselves in the healthcare facility, and because IPC basically has a lot of things to do. It's not only what we normally see some of our IPC staff doing across the facilities, but then it's always a lot behind the table. So if you have any IPC person you can link with and you can share, he or she can tell you how IPC works. We have a WhatsApp channel. You can link that, you can join there, so that now you can be part of Let's Talk Nursing. As we move on, there is a question of why the government is risking Kenyans. I think Mr. Christopher talked about that. The issue of treatment was talked about. We don't have a specific treatment. So what we are managing is the clinical presentation management is what we are managing, and we still don't have a vaccine for Bundibujo virus. Someone is talking about the signs and symptoms. I think this one was talked about clearly by Prof. This is a structural. I think, Mr. Kibiwott, you need to talk about the hierarchy in terms of infection prevention control, because now there's a question of hierarchy on the can isolation place be in between the buildings? So I think hierarchy in terms of isolation IPC, you can respond to that, or in between floors.
Okay, about the hierarchy of controls, we have it is what we call an inverted pyramid. In these inverted pyramids, we always start with what we call elimination. Elimination here we mean we prevent a disease like Ebola from actually getting into the country by strengthening our borders, improving surveillance at our borders. You know, when we prevent it from getting into the country, we are actually eliminating the need for us to manage Ebola at any given time or situation. Number two in that hierarchy is what we call substitution. And a substitution in this case mean Actually, when we set up the facilities near the epicenter of the virus, it is like substituting it, making sure it does not spread to the rest of the country. We just control it where it has happened, and the rest of the country remains safe. Then we have what we call engineering control. Engineering control is actually what happens in the clinical settings. When we talk of marking clear flow of patients, that is engineering control. When we talk about putting isolation facilities, that is engineering control. When we talk about using IT, like when a patient, a suspect is at home, yours is just to make sure that you use WhatsApp to talk to the patient and gather the symptoms and all that. That is still part of engineering control because you are not directly in touch with the patient. Another form of engineering control is the distance. In fact, we encourage that when we're in the situation like we are in now, when you are in the triage area or you are the one clocking the patient, make sure that there is a space between you and the patient about 1 meter. And actually, when you use a table or a window pane with a clear glass where the patient is communicating from the other side, that is still part of engineering control. Then we have, in terms of hierarchy, administrative controls. This is also very important. We always say, when you have a well-trained staff to handle a situation like Ebola, that is the ring we are always talking about, the safety ring. We make sure that the Ebola does not spread to the rest. So when you allocate nurses, doctors to work in an Ebola treatment facility or an isolation facility, make sure that you put in there the most qualified, the well-trained nurses and doctors, so that there is no chance of that virus getting out of that isolation facility. Then the last is supposed to be PPE. Actually, in terms of the hierarchy of controls, PPE is our last resort. And that's why in the front line, we always talk about PPE, because in my opinion, all the other methods have not been working very well. From elimination, substitution, engineering control, and administrative control, they have failed. So PPE is our last resort, actually. And when we talk about PPE, we must get high quality PPE because it is our last chance of making sure that Ebola does not spread within the community. So those are the controls we always talk about. Back to you.
A little right down Kibiwott answer, and I appreciate Kibiwott said very well. I want to say that in terms of engineering control, every effluent from an isolation center, whatever the disease, must be treated before it is discharged or wasted elsewhere, because the chances of we talked a lot about sodium hypochlorite. Chlorine does not work very well in organic material. So there is a threat of carrying viable pathogens that can propagate an infection. So in that case, there is a repeat, now more rigorous, when it's outside the isolation unit before final effluent discharge or interment, because some of it is actually driven to very deep depth of the ground. So that is the rule of the thumb. So you may not be able to put an isolation unit anywhere you wish. It has to fit the standards. When I was asked to go and do Ebola preparedness in Busia, and they had some kind of a funny tent put completely in the wrong place, I went and condemned it. And I told the then the deputy governor was also doubling up the CEC for health. I said, please, none of you, and I repeated and I said, I reiterate, none of you should think of putting an Ebola patient here, because you're going to see me against you in the High Court, and you will not win. So I was reported to the office of the president, and finally everybody was shaking, thinking anything was go wrong. I gave my own reasons why I condemned it, and nobody disputed. It didn't have an access, it was in between buildings, it didn't have a discharge, it did not have a self-borne sewer system. It was within meters of borehole and hand dug well. So I said you will contaminate literally everybody, and for there to move next to patients, as again you remember we've said they had to mingle with other patients to reach the Ebola, and I said that is already exposure. So those are factors that nearly always the WHO has what you call a humanitarian engineering team. I did some special training with WHO on how do you set up facilities for an emergency isolation. Those things are considered. If they don't meet, you literally have to go. Thank you.
Thank you so much. That was very, very great. That was very, very great. So we're taking one last question from Duncan. Then we go for the last two comments. Then we do the parting shot. So, Mr. Duncan, what's your question, please? Mr. Duncan Msangi. Mr. Duncan Msangi, I assume now that is a mistake when you're raising your hand. Okay. So I'm calling upon Mr. Wilson Laela, who was the team leader for Sierra Leone, to give us a short and precise comment on how things went and how he sees what we should do as a team. Mr. Wilson, welcome.
Thank you so much. Good evening, colleagues. I work with Kajiado County government, and yes, we went to West Africa. There was a team for Liberia, and then a contingent went to Sierra Leone, which was among them. We were lucky that we went at a time where cases were not as high as they were before. And I think the most important thing is that when measures are put in place, because I remember we went there, we were trained for almost 4 weeks, almost 3 to 4 weeks, thorough training of how to put on PPEs and, so many other things about surveillance and so on. So I think what we need to mind is to encourage each and every one of us that in case Ebola comes into the country, because it's already at Uganda, I think we should encourage ourselves and hope that the government will put on good training facilities and have enough PPEs and proper ones, not just PPEs which are not in good quality. I think the most important thing is we prepare ourselves psychologically that this is something we can manage because we have done it in West Africa, and we have seen Uganda doing it several times. I think Uganda team, even in Sierra Leone, had an experience. And I think we went there and we learned and we tried to manage, and we did the best we can. So mine is to encourage each and every one of us that this is something when measures are put in place and good trainings are put in place and facilities, I think we can manage. So mine is to encourage each and every one of us, because I've seen so many of us are scared about Ebola, but it's something we can manage. So thank you so much.
Thank you so much. Hats off for the team who went to West Africa, and you're making our nurses proud. Me, myself, I'm so proud of you guys. Bridget, are you there? Bridget Kagwiria?
Yes, I am here, Silvester, and thank you very much for the opportunity to say a word. I'm very honored. I will not repeat what colleagues have just said. Prof, very nice to connect and hear you give lots of wisdom. Thank you, Wilson, especially on the parting shots that you just gave. Somebody has their mic on, Silvester.
Yes, Mr. Duncan, kindly mute. Thank you.
Thank you. So I will not repeat anything that has already been said. I have sat in the corridors of technical coordination. Kudos, and a million kudos to Kenya nurses We are always leading. Wherever I sit in this front and I hear the accommodations that come out because of what we have done, I feel very proud as a nurse. Now, I need to just highlight 3 key points. Colleagues, please don't be a hero in Ebola. Ebola has no heroism. Ebola is an highly infectious disease. Follow every single laid upon IPC measure. Do not take any shortcuts. I've seen somebody asking if an Ebola patient is brought to their county if they can handle. No, you cannot handle because you do not have isolation facilities, and it is not every county that has the capacity. At the moment, I'm not even certain that we have already identified our isolation centers. There is a lot of politics going on around Kenya, hosting this or that. I will not mention any bits to avoid being misquoted by anyone. But I will tell every colleague, please do not be a hero when it comes to Ebola. Please follow all the IPC measures. Secondly, we have many of us who went to West Africa. We have many of us who are back here. I would like to ask all of us, how many of us who have been to West Africa and back have been mapped as part of their 118 healthcare professionals that have been said are out there and ready to be deployed? I'm saying this because WHO, Ministry of Health, partners in the name of NGOs, Red Cross, they're all working together with very many meetings happening, almost like 2-3 meetings a day. And there is already an advocacy that is happening even at Africa CDC level. Yesterday, there was a very high level meeting that was convened by the Director General, Dr. Jean Kasiwa, who said something very, very interesting. He will do everything possible to advise the governments what they need to follow as far as Ebola is concerned. It is the autonomy of every government, and therefore in Kenya, we come back closer home. The government at national level, the government at county level are working all together. I urge every nurse now where I am, please follow, please read, please be informed. I congratulate Leonard and his team who have taken time to bring us together. Please do not wait for this moment to be brought together. Just read, just Google, on LinkedIn, on Facebook, check our WhatsApp statuses. Some of us are sharing these things on a very, very frequent level. Follow up Wilson, follow up Joseph, follow up Bridget, follow up Stella, follow up everybody else and ask, please give me what you have about Ebola. If you are at county level, dear colleagues, do not wait until information comes to you. You can actually initiate that information yourself to protect you as the individual. Remember, you're part of a bigger society. Who is your family? Who is you? Who is the patients and the colleagues with whom you work and the patients that you serve? My last point will be, there are a few laid upon procedures by the National Public Health Labs that not procedures, but information materials that are there. Leonard will share with us. But I also urge you, colleagues, when you just go online, you will find it. Let our WhatsApp statuses be our education, not with propaganda. Please do not post propaganda. Do not post what is not supposed to be posted. Please do not put gossips. It's not time for gossip. Whether we like it or not, I was in a different webinar last night where somebody said, whether you like me or not, please spread facts. It is not time for nurses because they belong to Let's Talk Nursing, because they belong to Silvester Network or Joseph Network or Wilson Network, that we speak against one another. Let us hold each other up as nurses. And as I close, I say, do not be an hero in any outbreak. Take care of yourself, take care of your family, take care of your patients, take care of your colleagues. And please, nurses, I know some of us do not like this person that is called a patient attendant or a nurse aide, but this is the person who is supporting us in our daily care. When you have information, please share with them. You don't be the regulator. You and me cannot be the regulator. Those of us who are lucky to sit in the regulatory frameworks, yes, but we cannot be the regulators. So let us share information with our nurse attendants, our cleaners, our cooks, our tea people, our watchmen, our everybody that we have around us. And please share only the right information. Thank you very much for being amazing colleagues. Kenya is shining out there. Kenya, we are heroes. Kenya, we are doing great. Kenya, we are amazing. And we can still remain amazing. But Kenya cannot be Kenya without you and me. Thank you very much. Be blessed, nurses. And let us keep shining together. Thank you.
Great flowers to all the team members, those who have shared the experiences and those who have also shared with us, whatever is there. So I'm not taking any question. We are going to have these sessions in coming days as we move on. We have the management part of it. We are going to bring the team who went to Sierra Leone to help us on management part of it. We are also still going to keep the surveillance team headed by Professor Joseph, and also the infection prevention team. Also, we'll also have them on board. So basically, Mr. Christopher will also still be with us in terms of disaster management. I'll still be there in terms of infection prevention control moving forward, so that now we ensure that our country is safe, our healthcare workers are safe, our nurses are safe, and everyone around our patients are safe, and also our patients are safe. So at this point, I'm going to give a parting shot for each and every person. So we'll start with Lucy Kanyi. Do you have a parting shot? Are you still there, Lucy?
Yes, I am.
Thank you.
Just like Bridget has said, do not try to be a hero when it comes to Ebola. Ebola is not COVID. Ebola is not flu. Keep safe. Be vigilant. Know your neighbor. And as Kibiwott said about hand hygiene, let us also be very, very vigilant with hand hygiene right now as you're using public means. Even in your private vehicles, do not think you're safe, because you may never know whoever gets into your vehicle, where they came from. So let us keep safe, and let us also be observant. For those who are in the borders, please, Kibiwott also said, let us be very vigilant, because like we saw it on TV the other day, when they are taking temperature, it is just like a by the way. Let us follow the infection prevention and control measures to the last point. Thank you.
Thank you so much, buddy, senior citizen. Thank you so much. Mr. Christopher, parting shot?
Okay, my parting shot as colleagues, we all know the case fatality rates. We all know the transmission routes. We all know isolation protocols, but knowing is not enough. Not when a single lapse in a trial moment or an assumption on a PPE can actually expose each and every one of us. So we have to be very vigilant, because any lapse costs life, not only your life, even that of your patients and the ones in the community and your family. So the first and last line of defense, not just for patients, but for ourselves, our teams, and the communities who look after us is the calm composure. We know it is a dangerous thing, but we need to approach it with calmness that it deserves. And actually, in every emergency situation, calmness usually wins the day. And remember, whenever you have donned your PPE very well, you don't have anything to fear. And we have everybody watching over you. Always double check your PPEs and don't miss any case, because actually our first defense is early identification of cases, reporting and isolating them as soon as it happens. So we need to do it one day at a time. As I know, at the end of the day, nurses will be the ones actually fighting this Ebola if it happens to come, because actually the doctors, they just come, they can look at the patient from the window, that is the engineering control, and leave. The people will be in the fire, will be the nurses. So we need to be actually well prepared as we advocate for systems to actually notice what we are doing and support us as need be. Thank you.
Thank you so much, Mr. Christopher. Professor Joseph, parting shot.
I want to thank everyone that was able to join in. I kept monitoring. We reached over 300, and we have been going. Figures are changing and changing, and so we've cumulatively most likely we have had about 500 participants. Sometimes in February this year, I did announce there will be a new hemorrhagic fever that will be hitting Africa. It's not that it's not the Bujibujio Ebola. That is not what I had seen. But it was supposed to start in northern Nigeria, and it's also supposed to hit Kenya. This is supposed to be a new one again. It's looks like it's a Lassa fever that has gone wild. Lassa fever also becomes a hemorrhagic fever. The route of transmission largely is through rodents. The rodents that eat on your food, do whatever, then their saliva, the urine, whatever can spread. Currently, it's already a threat in Nigeria. It's basically in about 3 or 4 of the northern states. So we need again to also keep abreast and also watchful, because anytime it could hit Kenya. I don't want to speak much on how I thought it would be introduced in the country. I am a well-trained disease intelligence officer and have detected a lot about terrorism attacks in our country in the past. So I have been monitoring, and so far I've not lowered the risk level, but let's keep watch. Again, nurses will be in this, and that's why I just mentioned it, because I know I'm talking to responsible nurses who are doing this. The last thing I want to say is that I'm so impressed with the team that was presenting today. I want to ask Let's Talk Nursing to bring us into a caucus so that we can talk of the presentation. I think this is a great team, greater than I've ever had actually before. Thank you very much. God bless you. Have a good evening, and all of you I love you.
Thank you so much. Thank you so much, Prof. To this juncture, I'll just remind you, Let's Talk Nursing is a platform that is placed to help sharpen each nurse around the country and overseas. And we bring presenters in with different ideas, with different knowledges to help us sharpen each other. So today's presentation was basically done by Professor Joseph, who is also a retired nurse and a senior citizen with a background on communicable diseases and surveillance. Part of it was also another nurse, who is Mr. Christopher Kibiwott, who was trained on infection prevention and control as a specialist, and also in disaster management in the overseas, somewhere in Israel. Then we had our experienced experts, that is Lucy Kanyi, who is also a retired citizen, who is also a nurse by profession. She was trained in neonatology nurse. She's a neonatology nurse and also infection prevention and control specialist, retired, and also helped us in West African team. Also on board, we had Bridget Kagwiria, who also was part of West Africa team, and Mr. Wilson, who also was the team leader for West Africa and Sierra Leone. Linda, kindly mute. Gladys, kindly mute. Speaking to you is Silvester Owenda, a nurse by profession and a specialist in infection prevention control, and also a forensic medical examiner within. So we'll share knowledge, we'll continue helping each other, we'll continue sharpening each other. And at this juncture, I'll give Mr. Leonard Otieno to give us a small comment. Then we finish up with Mr. Jeftas to give us a vote of thanks. So we are going to keep in touch. We are going to have the next session on management of Ebola case as we move on until we ensure that each and every person has the information they require. Thank you so much. And Mr. Leonard, kindly come on board.
Okay, thank you very much, Silvester, for moderating this session. And I'm really happy with our presenters who are really up to this case. I know quite a number of people have been asking about clinical, case management. And just like Silvester said, we'll keep talking to Christopher, Professor Njau, Lucy, and Silvester himself, so that at least we can organize for some sessions when it comes to case management of Ebola, and maybe in case of any other additions or any updates that might be needed, we'll keep sharing in our channel and also invite you for more webinars. So thank you very much. I don't have more to say, but you are much welcome in Let's Talk Nursing. Let's get these updates daily. I know we are having quite a number. We normally have our bi-weekly webinars. On 5th, we might be having another webinar, though not related to Ebola, but we'll be having one on ECG interpretation. And we have a series of them every, bi-weekly. Thank you very much.
Sorry, Leonard, I know this is rude to interrupt, but because Ebola is a really high alert for nurses, would it be in any way okay for you and your leadership team to organize on-demand kind of webinars as information comes across, so that we assist colleagues who are not able to get information individually to stay, work, and get information appropriately?
This is well noted, Mentor, Bridget. We can always be organizing several of these webinars we come. And again, we can as well maybe postpone our other webinars so that we focus on this for some time, so that at least we get people enlightened, we get people to know the information when it comes to Ebola. Thank you very much.
Thank you so much. Thank you so much. Thank you so much, team. That was a great work. That was a great.
Silvester, sorry, I'm seeing someone is asking whether we can share the recording. Yes, we'll do the recording. We have Let's Talk Nursing YouTube. We'll upload them in our YouTube, then we'll share the YouTube link for maybe people to listen and also to get more information. We also have a channel. People are saying that it's not working, but I've sorted some other people. So it is working. You can also get into the channel so that you can be getting this information daily. We have a WhatsApp group, but it's full. So for now, we advise people to join the channel. Thank you.
Thank you so much. Thank you so much, Mr. Leonard. So at this juncture, allow me to bring on board Mr. Jeftas so that he can close for us. And to each and every person, we thank you so much. We appreciate your time, and we are ready to support you at any point. You just reach out to us. We'll support you with all the skills and all the knowledges that we have for your safety and for our safety and for the safety of our nation and beyond the borders. Thank you so much, Mr. Jeftas. Welcome.
Wow. Thank you very much, Mr. Silvesters, and good evening, everyone. As we conclude this important and timely session on Ebola preparedness and response, as Let's Talk Nursing, we would wish to sincerely thank our presenter, Professor Joseph Njau, for the outstanding presentation. Everyone here can attest that we've learned because of your extensive knowledge, practical experience, and evidence-based approach that has provided quite invaluable insights. We also reminded that the lessons that you've shared from the previous Ebola outbreaks, including the long-term management and surveillance considerations associated with Ebola-affected communities and the burial sites that should be under security for 15 years, have broadened our understanding and strengthened our preparedness. And as Let's Talk Nursing, one of the team leaders, I think the government should recall you from your retirement and take you to lead our Ebola preparedness. We also extend our appreciation to our Ebola champions, panelists, Mr. Silvester, and your team from IPC team from Kenyatta, for enriching the discussion through your expertise with quite extensive knowledge and experience in IPC. We really appreciate your perspectives and the commitment to public health and patient safety, and we applaud you for that. Also, to our audience, thank you for your active participation. It was quite a long CME, and we've taken like almost 2 hours, 45 minutes. It was your thoughtful contributions and commitment to professional growth, and your engagements reflects the resilience that defines healthcare professionals. Today's session has reminded us that infection, prevention, and control, as alluded by Kibiwott, we must just move beyond the theoretical knowledge into daily practice. And the effective outbreak preparedness require teamwork, vigilance, accountability and communication, and consistent adherence to IPC standards by every healthcare worker and every healthcare institution. And we are cautioned not to be heroes of Ebola. Ebola has got no friend. It is not a cholera or a COVID-19. So as healthcare professionals, we must also continue to advocate for strong systems that support safe practice. We call upon the Ministry of Health as Let's Talk Nursing, the Nursing Council of Kenya, nurse service managers, healthcare facility leaders, and public practitioners to always continue strengthening the standards, policies, training programs, surveillance systems, things like emergency preparedness and resource allocations to strengthen our IPC protocols for the healthcare safety. We also, as healthcare workers, we can only perform optimally when supported by robust systems, like in the current case of the Kenyan and the US government. We need adequate equipment, continuous professional development, and effective leadership that has been emphasized by members. And on behalf of Let's Talk Nursing Network leadership, we reaffirm our unwavering commitment to empowering nurses and advancing nursing excellence in Kenya, across Africa, and even beyond. We've even invited global nurses to be part and parcel of Let's Talking Network. We remain dedicated to mentorship, training, coaching, leadership development, advocacy, and professional support for nurses and even in institutions. Through collaboration and continuous learning, we seek to strengthen healthcare institutions and improve patient outcome globally. As we leave this forum tonight, let us continue to champion evidence-based practice in regards to Ebola case managements. We also require professional accountability, resilience in our work and teamwork, and also excellence in service delivery. Let us remain vigilant, always remain prepared and united in protecting our communities from emerging and re-emerging public health threats. To our presenter, Professor Njau, we are quite happy with your presentation, and we are certain that the knowledge we've obtained from your presentation, we shall implement. Also, thank you for this session, and also for Mr. Silvester, thank you for making this session a successful one. And together, through knowledge and resilience, we can build safe health systems and save lives as nurses. Thank you all for all the audience. May God bless all of you. And I would wish everyone a good night. And thank you all. We can now declare the CME officially over, and you can leave at our will.
And maybe as we go, I was just trying to get the facts. So the National Public Health Institute has been mandated by the Cabinet Secretary for Health to lead the preparedness and response efforts for Ebola. So whoever has any questions or clarifications could follow up directly or through the leadership.
Thank you very much for that. In fact, after this presentation, we feel confident now to at least face the Ebola, not head on, but based on evidence-based practice that Professor Joseph Njau has enlightened us with. Professor Njau, we are quite lucky to have you around. We are so happy. We are so impressed. I think you are not retired. Once a professor, always a professor. And we wish to emulate you.